So when you think about the modern management of advanced uveal melanoma, how do we manage patients nowadays with all this knowledge that were acquired across years and years of research? Is that once, and this is our center reference treatment algorithm. So when we see a patient with the diagnosis of metastatic uveal melanoma, this patient will be most of the times will be those patients that were diagnosed with a primary lesion in the eye, and then he underwent treatment, and that patient underwent surveillance with imaging, and on surveillance, imaging detected a new lesion, and as I said, most of the case in the liver. So those patients undergo a biopsy of the liver lesion to make sure that that is a metastatic uveal melanoma, and then what we do in our center is that we test these patients for HLA so we can stratify systemic treatments moving forward. We also discuss this patient's case in our multidisciplinary tumor board, where we gather consensus from our colleagues, uh, and we always do what we call comprehensive genomic testing for these patients in order to try to match patients to clinical trials, prognostify as well. And when those patients are HLA-O2/O1 positive and they are eligible, we discuss with that patient that we favor tebentafusp as a standard of care approach as first option of treatment. Once this patient, when we do the HLA, but that patient is not HLA positive, so he's HLA negative for the HLA-A02 haplotype, then what we favor for those patients is that we try as much as we can to enroll patients in clinical trials across our institution. In a very selected populations, once we do the screening, the testing, the workup, we might discuss immune checkpoint inhibitors, immune checkpoint blockade, similar from cutaneous melanoma, but this is less likely, and this is only for a very selected population of patients. As well as focal therapies, as I show, we have various techniques and options that we can offer patients as well. And once those patients that were being treated with tebentafusp, and unfortunately tebentafusp is not working really well, and we feel that this patient will benefit, needs to undergo another option of treatment, and then always clinical trials is the option, the way to go, is that what we favor to patients. So as concluding remarks for our talk today is that approximately 50% of patients are not eligible for tebentafusp. We discussed that this is an HLA selected or HLA directed therapy. Clinical trials are crucial. I strongly advise patients to ask their physician for referral or to receive information about clinical trials and discuss with your physician about possibility of clinical trials. For this disease that is rare, as I said, or is only happens in across the US in 5 million of patients every year. This treatment needs to be personalized. This disease is heterogeneous. It requires a personalized treatment approach. It requires a discussion across multidisciplinary tumor boards to tailor the best treatment for this patient. And as we will discuss in future talks, our promising therapies are being tested nowadays, and are very large trials with results that are highly awaited, that are very promising, to change or to offer newer opportunities to improve survival outcomes and to offer new therapies for patients. So I think that will all of our discussion for today. I thank you so much for your attention.